a couple of minutes. Right about 12:30, so let's go ahead and get started. Welcome everyone to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speaker, I have a few announcements to make. This CME activity is jointly provided by the Queen's Medical Center and the UH Jabsom Department of Geriatric Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You will find evaluations by following the link in the chat at the end of this talk or at any time on our website or our email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. It's my great pleasure to welcome our speaker for today, Dr. Ramona Wong. She's a local retired nephrologist and dialysis unit director. She's the creator of Aloha Kidney, which was active in prevention, management, and transitions of chronic kidney disease. She has also been very active in providing free public health education and comprehensive services, and also has been doing a lot of healthcare workforce services as well. Her current passions are oneness, regenerative gardening, and agroforestry. She has rescued a Swedish black mallard and a 13-year-old deaf and lame toy poodle. Wow, that's amazing. And she said her current passions are not giving grand rounds, but I know she's going to do a wonderful job for us. So please join me in welcoming Dr. Ramona Wong.
Thank you, Kamal. Thank you for allowing me to be here. Hi, everybody. And I know some of you, thank you for tuning in spite of knowing who I am. But I'm going to share my PowerPoint. Let's see if I can do that. Okay. So I know I think the topic maybe that was sent out was more about what would you do if your mom or dad was diagnosed with advanced CKD today? And but in essence, from my perspective, okay, if you have advanced CKD stage 4 or 5 suddenly, or the need for the decision um, about life prolonging versus um, medical management only because of kidney failure. And if it just suddenly lands on your lap, then now what? So hopefully, let's see, does this work? Yes. This is me. Hopefully, you have a plan. But if not, then this is what the talk is about. And I'm very retired, so please know that I'm not cutting edge in any way. And really, the only reason that I agreed to give this talk is because there was the perception of your planners that there wasn't wide understanding or awareness even of the guidelines that were published back in 2010 by the Renal Physicians Association on shared decision making about withholding or initiating dialysis. So I thought those guidelines are very important to me, and I would think it would be useful in anybody's practice who deals with people who could end up with kidney failure, and certainly in a geriatric practice. So my disclosures are that I am Aloha Kidney, and Aloha Kidney is a free series of online classes now, thank you to COVID, for anybody to view at their convenience when they want. And it's a pretty lay language, it is lay language, comprehensive kind of course in how to prevent, how to manage, and also the transitions ahead and how to plan for them with regard to kidney function and kidney disease. So, so that's my disclosure, because I will unabashedly suggest that it might be useful periodically through the talk, but they're free. So, it's not that I do it for any monetary gain, and I feel pretty non-conflicted about talking about that. So I think first, I think you have to understand me a little bit and my perspective when I talk to patients and talk to you about anything, is that I have kind of this perspective that we all come from this eternal source or life or energy. And at some point, even scientists, right? Scientists say that energy is not created or destroyed. So we come from this one huge energy, eternal, infinite pool of energy. And we come out and we're born into this body. And so for this period of time, we have this experience in this bodily form. So we're energy in a bodily form. And then at some point, the body dies and we return to this kind of infinite, eternal pool of energy. So so it's not in a sense, it's not life or death. It's birth or death, and we're always alive or we're always energy. But so we talk about this as well in classes, just so that I want to remove a little bit of the fear based discussion on death. Just at least to put it in a broader perspective, because I think whenever we talk about death, there's always this, oh, it's the end and there's nothing, or who knows. I'm true, who knows? But I like it that scientists have shown that we can't create or destroy energy. So there's some sense of, ongoing life energy, so that we can kind of remove some of that fear factor that prevents understanding or becomes irrational. But it also kind of bookmarks or bookends the birth and the death. This huge gift of a bodily experience, which we each co-create by the choices we make in each moment. So it helps us. I think it helps me to conceptualize and to communicate to the people that come to classes that, okay, we're talking about this time and body, which is a huge gift. What do you want to experience? What is it that, and I'm going to ask you, what do you want to experience while you have this body? And what kind of experiences do you want to go through? Who do you want to spend your time with? What's important for this time in body? And so I think it helps to kind of step back and look at it in this way. And so that's kind of the framework for how I think all of us can, or it's one framework, it's not necessarily the best framework, but it's the framework that I feel has some value and has helped some of the people who come to class with CKD to be less of the deer in the headlights kind of look that they have when they first come to class. It helps them to be a little bit more grounded and thoughtful about what it is that they want, and realize that they have this power that they hold, that they're co-creating their ongoing experiences. Okay, so I think the two questions I ask them is like initial homework is, what do you want to experience while you have a body? And about how much more time would you like? Because based on those two answers, which most of them have no idea when they first come into class that this is going to be their assignment, based on those two answers, then we can move on to, and they need to think about those things, and I would like you to think about those things as well. Then you have to ask, what are you willing to do to get there? Once you have your goals of what you want to experience, and of course that's fluid, it will change with time, but for now, and it's good to reassess those periodically, then what are you willing to do to get to your goals? And sometimes, like with advanced CKD, they don't know what the options of willing to do means. So for example, especially if they're late stage 5, many of them don't even know what dialysis is. So how would we even begin to ask them to answer, do you want dialysis or not? Or so it becomes more of a fear-based, oh, I don't want to die, so I'm going to do dialysis. Or my family doesn't want me to die, so I'm going to do dialysis. So it's more of a kind of reactive kind of thing rather than an understanding what it is and then deciding, I want to do this. This is what I'm willing to do to get more time in this body. So I think inherent in that question is that they're informed and that they have adequate access to information and understanding, not just information, but understanding, which is a big difference. So I think that's where perhaps something like education comes into play. And then they can start to begin to understand how we can work together, how they can work together with their healthcare team to get to where they want to go. So when I started the classes, this became a very useful addition and embellishment. This document that was published in 2010, it was a second edition of the shared decision making in appropriate initiation and withdrawal of dialysis. Prior to that, or well, they had the first edition, but and that was definitely eye-opening for me and helpful because there was data to suggest who would not do well on dialysis. And prior to that, there really was kind of just, it was kind of a random if you read these studies or not. And so it was very nice. It was very nice pulling together of the information to help nephrologists and patients. Well, it was for nephrologists or physicians or the healthcare team to draw on to help provide the patient with information that could maybe aid in their shared decision-making process. So what is it? It's evidence-based adult and pediatric recommendations. I don't do pediatric nephrology, so I really didn't delve into that part. But it provides rationales and strategies for the implementation of each of these recommendations. And it gave a toolkit of validated instruments. So I think you'll have received a summary of the recommendations, and you'll also receive the actual recommendation book. So, you know, the 100-something pages plus. So if you want to look at and dive more deeply into the science behind these recommendations, it's provided for you in the book. But the synopsis or the recommendations themselves, the summary, is separately sent to you. I want to say thank you to Alvin Moss, who was the, Dr. Moss was the chair of the group that created this guideline. And he kindly let me share some of his slides on the guideline, which I will use today. And he allowed me to use them for this purpose. So you can tell his slides versus mine. Mine are kind of airy-fairy. His are very, you know, rooted in science. So, so the guideline, what I like about it is it highlights certain things that other literature has shown. So it highlights the very poor prognosis of some elderly stage 4 and 5 chronic CKD patients, and the fact that many of them will more likely die before they reach the intersection of decision making, whether they decide on life prolonging versus, you know, whether they decide for or against life prolonging therapy because of kidney failure. So, and this is not just for the elderly, but it's more, I guess, prevalent in the elderly that that this will be the outcome, that they will pass from a cardiovascular event rather than from end-stage renal failure. So it's not only in the elderly population, but it's more obvious in the elderly population. And there is this online calculator, which I've never used because I actually retired around this time when it was published. This online calculator that can estimate, and again, it's all estimation, right? So it's an estimate of prognosis about how long people would live given their age, their, you know, some comorbid parts. And we'll show you this calculator later. Um, it the the guideline also highlights that there are distinctly different treatment goals for ESRD patients based on, you know, how healthy or unhealthy they are, and also, very importantly, what are their preferences. So that was the first edition of this guideline was the first tool that was useful in that way. And it acknowledges that there's often cognitive impairment in dialysis patients. So it also goes on to highlight that advanced care planning is important, and it should be the approach that we take for decision making for patients who lose decision making capacity. And we'll look at that a little bit further on in this talk. Um, it recognized the undertreatment of pain in dialysis patients, the underutilization of hospice in dialysis patients, and I'll show you some of those statistics. And it provided strategies to help nephrologists with being able to communicate some of the challenges and the prognosis based on the various treatment options. So I think it was very useful to me that this information was pulled together in this guideline. I guess I'd like to ask how many of you have read these guidelines before, or at least the summary of it. And if you want, I'll let you put in the chat box, which I'm not watching, but I'm just curious if you have or haven't known about these. And if you have, I'm sorry if this is like very elementary for you. But there are 10 guideline statements in the adult portion of this guideline, and it basically addresses 6 topics. So establish shared decision-making relationship, which I'm sure you all are very good at already. Number 2 and 3 were about informing patients, and that's where I think something like Aloha Kidney is useful because of the depth and complexity of chronic diseases, especially when it ends up having CKD in there as well. I think it's just not possible in the daily practice for a nephrologist or any physician to provide adequate information for them to make a decision. They have to learn from some other sources as well. There's just not enough time and not enough numbers of appointments that could do this. So education, while it can be delivered by the doctor, it's often not the most efficient way to do it. It's impossible to provide what the doctor provides as far as individualized information and understanding patient preferences. So, tying all that together is very important in the doctor's office. But as far as sort of the fundamental understanding of how do kidneys work, why is it, what do these labs mean? All those, what is dialysis and what is the process of dialysis? What are the different kinds? All that kind of information. It's not possible to communicate that in an office visit, and nor do I think it's necessarily appropriate. Some of it, yes, certainly with question answer, those kinds of things are the things that are important to share from the doctor's perspective, but the comprehensive education, I'm hoping I can fill that gap because it's like over 15 hours worth of material that's presented. And so hopefully that helps then the patient to go back and spend like the really important amount of time in the appointment to discuss in an informed way with their doctor what they want to happen. The fourth recommendation is facilitating advanced care planning, which again, you're all very familiar with and I'm sure you do well. Number 5 and 6 is about making decisions. And we'll look at these 2 recommendations about initiation and discontinuation of dialysis. Number 7 and 8 are sometimes very necessary and useful tools to resolve conflicts around dialysis decisions. So whether it's conflicts in the family with the patient or conflicts of the healthcare team with the family or a healthcare team with the patient. So I think there can be conflicts, and these two recommendations and the substantiating documentation and the rationales are helpful in those situations. And then number 9 and 10 are about providing effective palliative care, which I'm going to ask you a question about later. So number 9, providing effective palliative care, that's recommendation number 9, is really to improve patient-centered outcomes, to offer palliative care services and interventions to all patients with acute kidney injury, chronic kidney disease, and end-stage renal patients who suffer from the burdens of their disease. So I have always wanted access to effective palliative care at all those times. But I guess my question to you is that more readily available now that I've been retired for 13 years? I hope so, and I'm praying so, that outpatient standalone palliative care is available and effective. But I'm going to ask you that afterwards when we have a Q&A. I'm going to have a question for you. So that's one of my questions. Recommendation number 10 is to use a systemic approach to communicate about diagnosis, prognosis, treatment options, and the goals of care. And so I'm curious about that too, is there a systemic approach, or is that left to the nephrologist to have one? Or is that, whose kuleana is this, and who does provide this, or does this happen? Or is it kind of, catch as catch can and randomized? So I think there are still a lot of gaps in the system, and there may be forever gaps in the system, but maybe if there's a priority of which ones maybe can be more impactfully worked on, I'm the cheerleader. Like I would love to see the outcomes reached rather than, it takes talking about it first, and then it takes consensus, and then it takes action to improve the system. By no means is any of that easy. Another point of the guidelines is that treatment goals will differ. So people who choose aggressive therapy with dialysis without limitation on other treatments, that's what they're terming rehabilitative renal replacement therapy. Some patients have a poor prognosis and they choose to dialyze in spite of the poor prognosis, but they limit other things like CPR, intubation, et cetera, because they want to have some kind of a balance between life prolonging and comfort. And they can, raise their hand and say, okay, maybe no longer do I want this at some point. And then there are other patients who decline all of the above and prefer comfort only and active medical management only. And I think that sometimes is not even offered to them. So I think these kinds of things are very important. There are provisions for when it's appropriate to say no to dialysis. So the patient says no directly. If the patient says no indirectly, maybe they're no longer able to express themselves, or they have no longer adequate decision-making capacity, but they've expressed it previously, in their advanced care documents, or they have, or the third one, the proxy says no, they've indicated a proxy, a surrogate, and then the surrogate is well versed in the documents that the patient has created, and or it's been clear that the patient did not want dialysis, or the providers say no. So patients with irreversible, profound neurologic impairment that lack signs of thought, sensation, purposeful behavior, and awareness of self or environment, the providers can say no, but that is not always a clear no, and it will, I think, have to go through some of the algorithms that is provided in the document as well. So some of the predictors for prognosis for ESRD patients, I think, is useful to know. So age is one of them. And again, these are taken in, right? nothing's absolute, but age is one of the predictors of prognosis. Is again estimating prognosis, right? Functional ability, nutritional status, and comorbid illness. And so some of the recommendations is that all patients with AKI stage 5 CKD or ESRD should receive patient-specific estimates of prognosis. So we can't go and use any tool for every patient. We have to incorporate, right? Each patient is unique and they have their unique scenarios. And so there's the judgment that comes in addition, on top of any data or statistics or prognosis calculators, right? But so from what we know from the data is that if there's 2 or more of these conditions, then there's likely to be a poorer prognosis. So older than 75, older or equal to 75. And again, I don't want this to come across as ageism, because there are 75-year-olds who are very healthy and there are 75-year-olds who are not very healthy. So again, but 75 years was in one of the studies, the number that seemed to matter. The high comorbidity scores, and the no to the surprise question. And I'm sure you guys are much more familiar than I am with the Charlson comorbidity scoring, or marked functional impairment, the Karnofsky performance score, and then the presence of severe chronic malnutrition. So if 2 or more of these are present, then that's what seems to translate into a worse prognosis for these patients. And so if you have a poor prognosis by this definition, they should be informed that dialysis may not confer a survival advantage. It may not improve the functional status over medical management, active medical management alone without dialysis. And dialysis, I guess, telling people that dialysis does have significant burdens. And I don't know if the word burdens is a little bit nudging, but there's definitely a price to pay, right, for dialysis. You have to be willing to do certain things, and there are certain risks of dialysis procedures themselves. So I think they need to be aware that those things could detract from their quality of life. So again, part of the fully informed shared decision-making process. Oh. And you know this one, would you be surprised if this patient died in the next year? And if the answer is no, then that's actually translates into one of the 4 poor prognostic factors. This is the calculator that you can go online to help estimate prognosis for a patient, kind of predicting 6-month mortality, who is on maintenance hemodialysis. So this is a hemodialysis specific predictor tool. And this is the study that suggests it's reasonable to consider age greater than 75, that in this VA study that showed that they were more likely to die than to develop ESRD, even when their GFR was very low, which is stage 4 actually. It's not stage 5 even. And this is kind of some justification to show the comparative survival of CKD patients over 75 years old with or without dialysis. And the lines are quite comparable. So it goes back to, what does the patient prefer? How to spend, what kinds of experiences are they willing to have while they have a body? I don't think you have to read all of this, but I think the basically, they're suggesting that elderly CKD patients should know that dialysis may not confer a survival advantage. Dialysis does have a price, they like to use that word, that may likely be detracting from their quality of life. I guess I hate to nudge anybody in any direction. So that sounds a little negative to me, more negative than neutral. So I like to kind of put in may detract from their quality of life. So I think it's up to you how you express that kind of thing. And there is this sense of pro-life, um, even at the end of life. So this unnecessary medicalization of death um, sometimes comes from that pro-life, wanting to prolong as long as possible, no matter what kind of thing. I think that that may be where this seems to come from. But yes, dialysis, even home PD dialysis is somewhat invasive and definitely costly and higher risk for hospitalizations. But again, I think it should come back down to not talking about tests, procedures, and hospitalizations, but more or cost. I think it should come back to what do they want to experience, or what are they willing to experience while they're in body. This is from the CMS manual, and it goes into the coverage of hospice benefit if you have kidney failure or ESRD, that if the patient's terminal condition is not related to ESRD, that they can receive covered benefits under both the ESRD benefit and the hospice benefit. So in other words, I think they're saying CMS is willing to pay for this. And that patients do not need to stop dialysis treatments to receive care under the hospice benefit. So hospice agencies can provide hospice services to patients who wish to continue dialysis treatments. And I guess I have a question for you is, again, this was not something that was happening when I was in practice, but I'm hopeful that it is possible and happening now. But I want to ask you what is happening. This is the data from 2009, so a while ago, but I've seen also, this is Dr. Moss's slides, but I've seen more recent data that still shows that hospice is underutilized in ESRD, where even when you withdraw from dialysis, so this is a 20,854 that withdrew and only 13,500 used hospice, even though they withdrew from dialysis. So it's like, is there any more obvious time to have hospice involved? I kind of don't think there's any more obvious time than this. So was surprising back in 2009, but unfortunately, it continues to happen now. Those who continue on dialysis, very few, 6%, who passed away were enrolled in a hospice program. And so there's definitely an underutilization of hospice, even though ESRD prognosis on patients on maintenance dialysis, their prognosis is much worse than oncology patients. And yet they have, I know that's a very broad statement, but late stage oncology patients, so late stage kidney patients on dialysis have a much worse prognosis than late stage oncology patients, and yet so few gain access or obtain access to hospice benefits, which I think is a huge area of improvement, a huge opportunity for improvement. The other thing that was sad to me was that pain in ESRD patients is common and often severe. Not kidney pain, it's pain from other areas or different places of their body. It definitely impairs their quality of life. It's undertreated in 75% of ESRD patients in these studies. And it's unfortunate that the nephrology community is unable to better manage that. But again, I'm hoping that there's more utilization of palliative care and combined resources and knowledge to improve those numbers. Dr. Moss was part of a study where they looked at the pain score initially in ESRD patients, and then by utilizing this World Health Organization analgesic ladder, the pain scores markedly dropped. So it's just that these patients were not being actively managed for their pain. And so that's another point of this guideline, is that they can be treated. We can help improve their quality of life by managing their pain better. And it's as simple as understanding how from the physician side, the healthcare provider side. And it's not just pain, but there's a huge number of symptoms that dialysis patients have. And so there's another tool that has all these symptoms and kind of can help with this tool to see where are the opportunities to help this person feel better and have a better quality of whatever lifetime is left. So, so that's the RPA guideline. And again, thank you to Dr. Moss for letting me use his slides there. It does go over prognosis prediction for ESRD. It talks about individualizing goals of care, the use of palliative and hospice care in all aspects of kidney disease, and improve pain and symptom management. So hopefully, if there are any questions about those things, you have the resource now, the source of the information in your hands or as an attachment in your email, so you can take a look at those things and help your nephrologists who may or may not know these things as well. So what matters? So the other thing I was willing to share in this Grand Rounds session was what the people who have come to Aloha Kidney classes have communicated to me about what matters to them. And so there are a few categories. So in their doctors, what they've told me or what they've sent in on their evaluations is basically these things, that their doctors are caring, and that they feel that their doctors are caring. So their doctors may care, but if they don't come across as caring, then patients don't feel that they're caring. It's one of those things. What's your language of love? And so if your language of love is words and your partner gives you gifts because that's their language of love, then you may not feel, but never tells you I love you, you may not feel loved. So it's really realizing, how does your patient, what does your patient want, and how do they communicate? I think that's somehow it would be useful for us to figure that out for our patients, about our patients, and then communicate with them in those ways. Of course, all in a 15-minute or 20-minute appointment. That's really hard. They want their MDs to be knowledgeable. Some of them actually resent learning something that their doctors haven't told them, and say, well, why didn't my doctor tell this to me? And why doesn't my doctor know about this? And I frequently remind them, when those kinds of attitudes come up, is that they are the CEOs of their bodies. We each are the CEO of our body and our bodily existence. And so it's up to us to understand. And however we get that understanding, whether it's through our doctors or through other sources, it's up to us. And so I congratulate them on learning whatever they can learn, and then working together with their doctor. It's a team. They've chosen the doctor to be on their healthcare team. So it's shared knowledge and shared energy to get them to where they want to go. So this is part of their kuleana too. So they want their doctors to be knowledgeable, but how can the doctor be all knowing? It's like impossible. So, and information is all available in the palm of our hands for everybody now. So, hey, we all have to work together to, gather and work together and towards their goals. They want their doctors to spend more time. I understand that, but it is what it is. And so I try to point out how they need to be very efficient with their questions, and how to be efficient, and how to have, the data that their doctors may need. If they're on blood pressure lowering medicines, well, they need to bring in their blood pressure logs. Then they have to do it in a efficient manner of record keeping, so that the information shared. So, I mean, there's a lot of things that we talk about that they want from their doctors, and we try to work out how to do that together. Um, they want to understand. And so they don't like it when their doctors talk to them about lab results and they don't understand the lab results, but they don't say anything. Um, they want they would like their doctors to ask them about their goals. But I also say if the doctor doesn't ask you, then the ball's in your court and you need to raise your hand and provide the goals to them. Um, they don't want judgment, they don't want scolding, and they feel guilty when they haven't achieved the pro-life goals of the doctor. So that there's work to do, and they want guidance how to get to their goals. And a lot of them say, I wish I knew about these classes earlier. How come nobody told me about these classes earlier? And we kind of go back about, well, you're the CEO. But it would help, I think, if there's earlier awareness, and I think there's more and more awareness of the education availability, not just for kidney, but for other things as well. What matters about their caregivers or their support people? They don't like to be nagged. And so the communication is so important between the caregivers and the patient. And I think none of us like to be nagged. I don't like to be nagged. And so I always feel like it's important that we ask how others want to be supported. Because we all are trying our best to support each other. But if nagging just makes them close off and, you know, turn off their hearing aids or like look the other direction, then that's not going to work. So I think asking how we work together is important. And then they want their caregivers and their family, they want to work together. And so that has a lot to do with family dynamics and collective, to achieve collective understanding of each other's goals, not just the patient's goals, but so I think this honest communication. I'm tired. I don't have I don't have the energy to help you right now. I mean, the caregiver can say that sometimes, right? So I think it's important to be honest and caring. And then on choice, they want understanding, because they feel like they didn't really know how to make an informed choice. They don't even know what questions to ask of their doctors until they understand. So that's where, again, other sources maybe of information are useful. So what is useful from the Aloha Kidney classes? I think they do gain understanding because the time available is more than what their doctor could possibly provide. Easy access is important to them, so that's why we went online whenever they get to see it whenever they want. They want to know about all their ESRD RD options, including the end of life, and they want to understand what food to eat. That's like the number one question: is what can I eat? What can I drink? And a lot of them go online to get information, but they get the CKD or the ESRD diet, which is there's no such thing as a CKD or ESRD diet. Everybody's different. And so, and some of them say, oh, limit potassium. I mean, if you're stage 4 or 5, even CKD, and you've never had a problem with potassium elevation, why would anybody think that that's a good thing to do? Because those are the healthy foods. So again, understanding what is appropriate for them is useful. Um, they like knowing they're the CEO of their bodies. They forgot that somehow, or they never knew that. And I haven't had one person come up and say, no, I rather just let my doctor decide for me. I haven't had one say that yet. So they feel like they can work together now with their doc. That they know they need a unique dietary counseling, and with all their understanding, they feel empowered, and they recognize how things are interconnected, how different organs are connected, how different people are, and the world is connected. So I think that it's useful for them to understand, or they've said it has been useful. They like educators that have energy, more of a upbeat attitude, and they like that they have hope even in the face of death, because there can be a quality transition to death. So the quality of that transition, we can never really approach unless you talk about it. So even though a lot of them are scared when we first start talking about death, which we talk about a fair amount in class, they understand what a quality death is now. Um, they they understand the concept of energy in a bodily form, and also that so that helps them, I think, with the fear factor a little bit. They love hearing from ESRD volunteers that share their story. That's like the icing on the cake. So I think that's I'm so grateful to the volunteers that are willing to share their stories through end stage kidney failure with people they don't know, and I think they like the fact that everybody in these classes is open and non-judgmental, and they would like that in whatever setting that they land. The local kidney disease education resources, and I'm using kidney disease education definition by Medicare, as far as the amount of information and the types of information that's shared. So it's a fairly comprehensive definition if you ever want to look it up in CMS. I think the local KDE sources are either Aloha Kidney, directly from the doctors themselves, or the Malama Kidney Center, which has a nurse practitioner who doesn't have CKD experience himself or ESRD experience himself, but he has come through Aloha Kidney classes, and he has been under the supervision of a local nephrologist. So he's providing that on a one-on-one basis. If you're referred to Malama Kidney Center by a nephrologist, that's what it requires, a nephrology referral. So I think those are the current sources of kidney disease education here. There is other local CKD information, and that's available through the National Kidney Foundation, the local chapter, as well as the national chapter online. Dialysis providers will provide CKD information and would actually like to provide more CKD patients with education. And you can understand why, because they see it as a feeder program for their dialysis units. And I'm going to say that publicly because I've said it publicly before. That's the way they look at going upstream to CKD before, and they have no expertise in this arena. I'm sorry, I'm going to say that too. But there's definitely a financial, whether it's subconscious or conscious motivation in the type of education that they provide. So allowing a vendor of ESRD services to educate CKD patients, allowing a vendor of ESRD services to educate CKD patients on their options is like giving Coca-Cola the right to educate your child on what they should drink for hydration. So I'm just going to say also, any transplant program in Queens, it does have a education program as well, but they too are somewhat of a vendor. It's just the way it is. It's nudging towards their services, which they provide proudly, but I don't think nudging is appropriate. I think absolute neutrality, presenting all the options is what's fair to CKD patients. Once they decide they want to do life prolonging therapy, then have at it. You can go to the dialysis programs to learn about what they offer and go to the transplant center to understand what they offer. But prior to that, I don't think it's appropriate for that to be their first education experience. So advanced CKD, now what? Well, hopefully you'll see it from my perspective, which I'm nudging you now. I'm kidding. But this is what I can offer to help. And I think you really should think about what would mom and dad want. Should that land in their lap? How would you help them navigate? So thank you. I'm done, and hopefully we can have talk story now.
Ramona, thank you for an excellent presentation. From our audience, I see some comments in the chat, particularly from Mike. Mike, would you like to unmute and talk and give your input, and then also if you have any questions for Ramona?
I mean, sure. Not much to expand on other than like I had a patient who end-stage renal disease, also had an early stage recurrent breast cancer, vascular dementia. The main reason for referring her to hospice was that she had a poorly healing sacral ulcer and had been gradually becoming more hypoactive, delirious, and just having a lot of pain. But the family was very hesitant to withdraw dialysis. And so we're trying to explore with the five hospice agencies, if any of them would be willing to take her while still continuing dialysis. And unfortunately, from their perspective, it was, the breast cancer was too early stage to be considered terminal. And the dementia, while certainly could be terminal in many other cases, there was a concern of that, there's too much overlap in the vagueness of symptoms and trajectory with dialysis to separate the two, and therefore they couldn't use dementia or any form of it like as a primary hospice diagnosis. So all of them rejected the case until the family eventually decided their mother had suffered too much and withdrew dialysis, at which point she passed away within a week while on hospice.
Any thoughts, Ramona, or from any of our audience?
Well, I'm saddened to hear that. Hospice benefits are, I thought, were offered those who are unlikely to live another 6 months. I mean, I thought that was kind of part of the criteria as well. And I'm pretty sure if you were to ask the surprise question, it would have been no. So I guess I'm not sure how. It would be nice to get all the hospices together to figure out, the reasoning behind those kinds of things. Or is it an economic problem? Is it economically a problem to have a person on dialysis and in hospice programs? I'm curious to hear what you all think as well. But and the other question is there, separate from hospice, is there an outpatient palliative program that this patient could have benefited from?
Yeah, I think Marina put something in the chat that's true, that you can only get outpatient palliative through the cancer center. Unfortunately, I think it's just a shortage of resources. There's a shortage of palliative care physicians, and so.
Right. So I don't, so I think that's definitely a gap, and I don't know how else to provide adequate care for somebody who suffers. And but there is an algorithm that they go through in the RPA guideline, but even the RPA and the leaders of this movement admit that in every location there are limitations, that we may be able to create algorithms or understand the issues, but until those gaps are filled, we're not going to be successful in reaching, or providing quality of life support in many of these patients. But I think the more we talk about it and the more we work together and the more passion there is that can drive filling those gaps, I think that's where it all starts. So that's heartbreaking to me, Michael. Thank you for bringing up that patient. sometimes, you can involve ethics committee, you can involve organizations, insurers. It takes sometimes just beating the bushes. And of course, that takes time.
Thank you. Are there any more questions or thoughts that anyone would like to share? We still have a few minutes if anybody would like to ask. Okay,
I have a question.
Oh yeah, please go ahead.
And thank you, Marina, for entering that. I have a question about when there is an ESRD patient on dialysis and a geriatrician on board, how active are the nephrologists in moving it in the direction of through this end stage life process? I mean, who are the active players? Or I guess I'm sure it varies with each one, but do you find it's more in the hands of the nephrologist, the geriatrician, the PCP?
Would anyone like to unmute and answer that?
Hi, Dr. Wang. I'm Cody, one of the UH Jerry faculty. It really depends on the situation and how they came to me in a nursing home situation. They're sometimes post-hospital or long-term care. And usually when I ask, it's like, this is what the prognosis looks like, and it seems like they're getting worse or there's some suffering. I always ask them, has anybody talked to you about other options, like you said? And have you guys ever discussed it with your family or whoever is invested in the decision making? And sometimes they say, oh yeah, the nephrologist suggested hospice or they suggested this. But if they had already gone to the hospital and ended up in a nursing home with me to do rehab, there was probably before that some kind of decision that we want to still try everything. So it's really important to ask, like, has anybody brought this up with you before? What kind of conversations have you had before? Let's talk about how things have changed. Yeah.
Yeah, it's a fluid situation, but
Yeah, so sometimes they just left it at, oh, we already decided this. We're gonna go to dialysis, and that was it.
Right. Yep. And they can change their mind either way. So
Right.
yes, I think always being open to having the discussion again. Great. Thank you.
Thanks, Cody, for that comment. Thank you to our audience, and thank you so much, Dr. Wong, again, for wonderful grand rounds. I just wanted to remind everyone, for CME credits, you do need to complete the evaluation, and Michaela has put the link into the chat box. Okay, thank you again. Okay, bye-bye.